This lecture is about antibiotic prophylaxis. Unlike other forms of antibiotic therapy, prophylaxis aims to prevent infection following exposure to a bacteria rather than treat an established infection. To that end, antibiotics are only required during the exposure to the bacteria, and therefore a single dose is usually sufficient. The choice of antibiotic depends on the bacteria that are likely to be encountered, and we're going to look in turn at surgical prophylaxis, head injury, longbone fractures, infective endocarditis, and rheumatic fever. Beginning with surgical prophylaxis, the commonest adverse event after surgery is a surgical site infection, or SSI, and the average incidence of this is up to 2.5%, which accounts for more than a third of hospital-acquired infections in surgical patients. As a result, the use of appropriate surgical prophylaxis is important, not only in reducing infections, but reducing the need for antibiotics to treat those infections. However, as with all antimicrobial prescribing, if this is done inappropriately, it drives resistance. These are the principles of surgical prophylaxis. Firstly, you need to choose the correct agent. And as with other prescribing, this must be directed towards the most likely causative organism, and you must use the narrowest spectrum of activity that you can. The dosage should generally be high because you need to achieve adequate serum levels, and the timing of surgical prophylaxis is critical. There have been many studies on this, and they've generally found that the appropriate time is 30 minutes before the first incision, and that the entire dose should be given at that point. In terms of duration, it's rarely necessary to give more than a single dose. The only caveats for this are when there have been significant blood loss, or if the surgery is prolonged beyond 4 hours. It's not possible to give guidance on exactly which antimicrobials you should be using. Instead, you should be looking at local guidelines, which have been prepared to account for the local epidemiology. This table is just an example of what that might look like. Turning now to head injuries, it's important to realize that closed, non-penetrating head injuries do not require antibiotic prophylaxis. It's a common mistake for doctors to think that if the patient has a base of skull fracture, that they require prophylaxis. However, studies have been done to show that this confers no benefit and therefore can only cause harm. However, if the patient has a compound depressed skull fracture or a penetrating spinal cord injury, they do require prophylaxis or preemptive treatment. An appropriate choice would be ceftriaxone plus metronidazole for 5 days. Turning now to open longbone fractures. The most important part of the care is that there's early source control, which means early washout and debridement, preferably within the first 5 hours. And surgical prophylaxis should be given, and one possible regimen is cefazolin 1 to 2 grams given in the first 48 hours. However, if there's a delay in performing the washout, or you have a heavily contaminated wound, then this may not be sufficient, and you may need to give preemptive treatment. And in this case, you'd be treating with a drug such as coamoxiclav intravenously for 5 days. Moving now to prophylaxis against infective endocarditis. There is a limited evidence base as to when we should give prophylaxis, but in general, we should give it to patients at high risk of endocarditis when we are predicting that they will have a bacteremia. Here are some general recommendations to follow. We should consider prophylaxis in patients with significant cardiac abnormalities, be they congenital or acquired. Patients who have prosthetic valvular material or prosthetic heart valves, and patients who've had previous infective endocarditis. In people who have normal hearts, then we should consider prophylaxis for dental procedures if there is going to be significant manipulation of the gingiva or the periapical region. If the patient is undergoing a genitourinary or gastrointestinal or biliary procedure, then ampicillin plus gentamicin as a single dose would be appropriate. And for dental procedures, usually amoxicillin as a single dose prior to procedure is effective. Regarding prophylaxis in patients who've had rheumatic fever. Secondary prophylaxis, that is, prophylaxis given after rheumatic fever, is recommended for all patients. The recommendations are that if there was no carditis, it should be given for 5 years after the last attack, or up to the age of 21, whichever is the longer. If there was mild carditis, it should be given for 10 years after the last attack, or up to the age of 21, whichever is the longer. And if there's carditis with a residual heart disease, it should be given for 10 years or up until the age of 40, whichever is the longer. The prophylaxis of choice is benzathine penicillin given intramuscularly every 3 to 4 weeks, or oral penicillin given every 12 hours. In patients with a beta-lactam allergy, they can have azithromycin orally as a daily dose. So in summary, prophylactic antibiotics are given prior to exposure to bacteria to prevent infection. In surgical prophylaxis, a single dose 30 minutes prior to the incision is usually all that's required. It's important to note that closed head injuries do not require antibiotic prophylaxis. And prophylaxis against infective endocarditis is usually recommended only if there's significant pre-existing heart pathology. The evidence base for prophylaxis against rheumatic fever is weak, but it's generally recommended.